Dr. Weaver is here. He is our ER physician. He's the ER physician director, and he's been here for 5 years as the director of the emergency room. And he's going to present today, of course, about heart attacks. So thank you very much, Dr. Weaver.
All right. Well, I'm glad that everybody can make it out. And I just want to start by saying that I'm going to be fairly casual. If you have a question, certainly just let me know. Don't feel bad about interrupting me. And we'll start here in a minute. I will say that I felt I had a pretty good residency where we had a pretty strong cardiology program, and they gave me a lot of great advice, except for the one cardiologist who recommended that I buy MCI WorldCom, which then promptly went bankrupt. So other than that, I felt good about that. So I'm a big fan of Quentin Tarantino, and I love his movie Pulp Fiction because it's not a sequential movie. It doesn't start from the beginning and go to the end. It starts kind of in the middle of the story and wraps up differently. So with that said, I'm going to kind of do my presentation in the same way. And we're not going to start from the very beginning and go to the end. We're going to start with the actually the answer. So the question that we're answering is, how are we treating acute myocardial infarctions today? And this is the one area in medicine where I think things have actually gotten easier instead of harder. What we've done is we've identified that the best way to treat a heart attack, a myocardial infarction, is to get them to the cath lab and get them reperfused as quickly as possible. So with that said, the focus of treating a myocardial infarction is to expedite the process of transfer to the cath lab, at least for a critical access hospital, because we do not have that PCI capability here. We need to get them treated and transferred as quickly as possible. So what you need to do is give them aspirin, assuming they're not allergic to it. Mild gastritis is not a contraindication because aspirin does make a big difference in myocardial infarctions. You want to give them oxygen support to keep their SATs greater than 90%. If you want to stop and talk about this for a second, we used to give everybody oxygen. Oh, you got chest pain, we'll give you oxygen. And there was a Cochrane review that showed that giving patients oxygen who don't need it does not improve their outcomes. In fact, it may have a negative effect. They believe that the oxygen has an effect on the coronary arteries, causing vasospasm and actually decreasing blood flow to the heart. So you only want to keep them above 90%. If somebody's less than 90%, give them oxygen, but don't crank it up. Just give them enough to keep them above 90%. You don't want to give them, you don't want them to be hyperoxic. Plavix 300 milligrams PO is what the St. Vincent Heart Center says to give. If you read some of the literature, it says if the person's over 75, you should only give them 75 milligrams. Since most of our referrals are going to the Heart Center, as routine, we give everybody 300 milligrams in the ER. And then you need to transfer for emergent catheterization and PCI. So the goals here, if you're at a facility where you have your PCI capable, then your goal is 90 minutes. If you need to transfer the patient, and that's 90 minutes from first contact with the healthcare provider. If you need to transfer, the goal is 120 minutes. So in our ER, we'd like to get people in the ambulance in 30 minutes from the time they first walk in the door, 45 minutes at the latest. That way, by the time they make the 30-minute drive down to the Heart Center, they have time to get into the cath lab and get that artery open. So if any of you are calling the Heart Center, this is the number you call. That gets you directly to a cardiologist. Feel free to put it in your phone now. This is the Heart Center that's on North Meridian in Indianapolis. When we call that number, and I will tell you, when I call that number, you speak directly to the cardiologist if it's from 8 to 5. If it's after hours, then you speak to the hospitalist that is working there. And they take the patients very quickly and are very easy to work with. So for those of you who have worked in the ER or worked around acute MIs or acute coronary syndrome, you might have seen in that first screen there are a lot of drugs that are missing that we talk about. Nitroglycerine, integralin, heparin, Lovenox, your fibrinolytics, the TPAs, beta blockers, morphine, statins. Now they're not necessarily excluded, But the whole point is to transfer the patient. And if you've got a stable patient and you've gotten the Plavix and the aspirin and the ambulance is there and ready to go, you do not want to delay that transfer to give them additional medications. If you have time, then you can start using these other medications. And if the patients are unstable, then you do want to address those instabilities so that they're safe for transport. So let me go through these medicines here. This is kind of just reiterating what I've been saying. Time is muscle. So except for aspirin, Plavix, and sometimes oxygen, all those other medicines are considered adjuncts. Their administration should not delay transfer for primary PCI unless medically required for patient stabilization. And for those of you, I've been saying PCI, it's primary cardiac intervention, which is where they place the stent. So let's talk about anticoagulation. Anticoagulation is recommended, and if you have time, then they recommend that you give a bolus of heparin. Heparin is preferred over Lovenox because if the cardiologist wants to stop it, if the diagnosis is wrong, and we're going to talk about that later, then your anticoagulation stops pretty quickly, as where Lovenox, once you've given the dose, you're committed to 12 hours of anticoagulation. Your dosing regimen is 50 to 70 units per kilogram, up to a maximum of 5,000 units. Again, since we are at this critical access hospital, we're going to be transferring the patient. You're probably not going to have time to hang a drip, but if you do have time to hang the drip, again, you do not want to delay the transfer for this. You can start a drip at 12 units per kilogram per hour. Nitroglycerine. Nitroglycerine still has a role in acute myocardial infarction, but there's been some data in the last, 10 years about inferior infarcts and how it has worsening outcomes with inferior infarcts. So you need to be a little bit more careful about how you give it. They still do recommend your 3 sublingual nitros. And then if the patient continues to have chest pain or has hypertension, then you can start a drip. A lot of times, if I've given the patients the nitro, they've gotten better, I know they're going to be transferred, I may just put some paste on them and leave it at that because we don't have time to hang the drip. The one thing you need to know is if you give the nitroglycerin, they show decompensation. They start becoming hypoxic, short of breath, sometimes more agitated. They may have an inferior MI. A lot of times you can see that on the EKG, but a lot of times the EKG doesn't show you the inferior MI directly. You have to kind of get at it through some of an atypical appearance on the EKG. And so you want to stop the nitroglycerin. The other thing is remember that it's contraindicated in people who are using phosphodiesterase inhibitors, which are the drugs for erectile dysfunction. Trade names: Viagra, Cialis, Levitra.
Have you ever seen that?
I have not.
I've taken care of scores of perioperative MIs, and it used to be monad, morphine, oxygen, nitro, aspirin, beta blocker. It was the same. I have never seen anybody decompensate from nitro.
I'm sorry, I thought you were asking about.
No.
I have seen the decompensation.
You have?
Nitro,
Okay.
yes.
Okay.
Yeah.
Right.
So I used to be. I love nitro. I would give it large and titrate up quickly.
Right.
This data started coming out, and then I started having a few patients who did decompensate, stopped the nitro, they got better, and so I have seen it.
Okay.
I think I've only seen it twice, but.
What do you mean by decompensate? Just real low blood pressure, or?
Yeah.
Low blood pressure, maybe become hypoxic because they have an inferior infarct, so the right ventricle is not working as well.
And it's when the right ventricle doesn't work well, it is extremely preload dependent. So when you put them on nitro, they vasodilate, and then they really have a problem. That's the issue with the right-sided infarct. So.
All right, morphine can still be used to treat chest pain. However, there was a study, I think it's called the Crusade study, which showed that patients who received morphine had a higher adjusted risk of death. So what they recommend now is that you give it for discomfort that's unacceptable to the patient. If they have some pain, you let them have it. If it's horrible pain, you give them the morphine. 2 to 4 milligrams, slow IV push every 10 minutes.
Was there any clue why that was? I'm just interested. I'll have to look up the study. I'm just interested. Is it the same thing? Maybe it vasodilates them, and then you have a few people that have a right infarction and get into trouble, or what?
Well, you know, I've read a review of the study. I didn't read the study itself. They didn't give a reason for it. I'm wondering if it's just that people who have more pain have a worse MI. So
Well,
yeah,
that's that may be a larger, and then when they infarct, obviously they lose more muscle mass and more mortality.
yeah,
I think there's a lot of data now that's just associative, and you don't have to,
No.
whether it's truly causative or not.
Right.
Yeah,
Exactly.
and it was not a, it
But I
was
think
a
when you get that-
retrospective, it wasn't a great study in terms of that. It was a retrospective study.
Well, when you get those associative associations, I think it does say, well, let's give enough but not too much. Let's not just blast somebody just to blast them.
Right.
Let's stop and think and then treat. And I think that's always, 99% of good.
Yeah, so that study was a non-randomized retrospective observational registry of patients with non-ST elevation and acute coronary syndrome. So, it's not your best study in the world by any means.
Okay.
So morphine can still be used. I would say use it a little bit less aggressively, and you should be fine. So what about the rest of the medicines I mentioned? So beta blockers still need to be started in the first 24 hours. They recommend oral over IV administration. Most of you probably remember it wasn't too long ago everybody's getting IV low pressure. They had some studies that came out that said this might not be the best thing for these patients. Somebody gets a MI that affects their SA node. You've given them a beta blocker, now they're in complete heart block or something like that. You've created a mess where you're going to have to pace this patient or put them on dopamine or something like that. Integralin was certainly our go-to drug 3 years ago, 4 years ago. Everybody was getting it who was in acute coronary syndrome who had an MI. Again, this big push for quickness of getting them down to the cath lab to get them treated in that 120 minutes. Integralin involved a bolus and then hanging a drip, and it was often confusing. I don't think Don's here with it being in micrograms, and so they've replaced that with Plavix. They both affect the platelets and keep them from.
Is that what I don't know what integralin is. Is
It's a
it
2G3B inhibitor.
It is, okay. So
Plavix does the same thing, but through it works further up the chain, so to speak.
Right, okay. It's okay, fine.
Fibrinolytics can still be used, but basically the outcomes have shown that if your option is a fibrinolytic or getting the primary cath percutaneous done in 120 minutes, you're better off to get that cath done with the intervention because you have less bleeding, intracranial bleeding, and you have better outcomes with the myocardium. For a while, they were trying to use, I think they called it augmented PCI, where you would give fibrinolytics and then you go in and do the procedure, and those people actually had worse outcomes. So that's now it's not suggested or recommended to do that. Statins are recommended to be used as soon as possible. It doesn't need to be done in the emergency room. One of the things that was interesting when I was reviewing this literature and I was unaware of is that they don't recommend starting with a low dose and titrating up. They recommend starting with a high dose. They particularly thought atorvastatin or Lipitor was the better drug, and they recommended starting at 80 milligrams a day. All right, so we've talked about the drugs and talked about the goal of getting to intervention within 120 minutes. We're going to go on to identifying myocardial infarctions or heart attacks. Does anybody have any questions about the drugs before we go on? Anything that you want me to expand on further? We're all good? Okay. So,
Oh no. That's what it looks like, he's being attacked by a bird.
A heart attack.
try that again. I'm a little
That's
disappointed.
maybe coffee.
A little disappointed. Sound didn't work.
Just slide it, just slide it. I can handle it. Shuffleboard. Perfect.
It's coming through your own speaker.
Yeah, I know. It's because
Plug that in. That's funny. Get it, get it.
Actually, I wish that
That's
would
okay,
do.
we get it.
I know. I've got another one that's coming up later though, so I need to have
Oh,
a
okay.
little bit of speakers working better. Let me get this hooked up here. So, kind of my whole point of showing that is that if a heart attack were that obvious, it'd make our life much easier. It's obviously not that obvious, and so we've got to look to how we need to treat our MIs. Since I'm here, we'll see if I can. Good, sound's working now.
Not sure if it is. I'll teach it for smoking.
All right,
It's
I've
not
got
the
the problem now.
cigarettes. There we go.
All right. All right, so sorry about the technological glitch there. We got it figured out now. So, obviously, heart attacks aren't that easy to diagnose. If I had a patient that came in and said, "This large, ugly heart just beat me up," it'd be much easier. So, we need to talk about heart attacks and kind of how they're classified. What we've been talking about in terms of transferring for acute MI is what's called an ST segment elevation myocardial infarction, or STEMI. And then we've got the non-STEMI, which is non-ST segment elevation MI. The STEMIs are much easier to diagnose because you usually have large abnormalities on the EKG associated with symptoms of a heart attack. So I'll go through the official definition here. Myocardial infarction is defined as a clinical event caused by myocardial ischemia in which there is evidence of myocardial injury or necrosis. Criteria are met when there is a rise of cardiac biomarkers along with supportive evidence in the form of typical symptoms, suggestive electrocardiographic changes, or imaging evidence of new loss of viable myocardium or new regional wall motion abnormality. Then we look at a ST elevation MI, diagnosed by ST segment elevation in 2 contiguous leads with greater than 0.1 millivolts, often associated with reciprocal EKG changes, ST segment depression in opposite leads, or new onset left bundle branch block that occurred less than 12 hours from pain onset. These need to be associated with symptoms consistent with myocardial infarction. This left bundle branch block, new onset, is often problematic. Patients don't have an EKG with them from a month ago or a week ago, and so you get a patient with a left bundle branch block and maybe chest pain and maybe it looks like it's cardiac and you're not really sure. So that's often difficult. Now let's look at the non-ST segment elevation myocardial infarction. These are a lot more difficult to diagnose. We really have to depend on the cardiac markers. You get an EKG that most of the time is subtly abnormal. Somebody has some chest pain. It's not horrible chest pain. They've got risk factors, and 3 hours later, 6 hours later, their second, third set of cardiac markers becomes abnormal, and now you can say, ooh, they had a non-ST segment elevation MI. So it's diagnosed by T-wave flattening or inversion. These changes are less significant, non-specific, making acute MI difficult to diagnose. These patients are often admitted for chest pain or acute coronary syndrome. The diagnosis of MI is reached when serial biomarkers become positive and are associated with symptoms of the MI.
And the clock doesn't start with that kind of.
No.
Like, it's only with STEMIs.
Correct.
Correct. With the, you have the 120-minute window or whatever it is.
Correct me if I'm wrong, and I don't know the data, 40% of MIs, there are no electrocardiographic changes.
Yeah,
I'll say that most of the time they're not flat normal. Most of the time there's some sort of EKG, but it's frequently nonspecific.
Right,
Yeah.
there's nothing pathognomonic about any of the EKG changes.
that is correct, and that we'll kind of address that later, which is why patients with chest pain who have a negative first set of cardiac markers are admitted, because it's hard to rule something out 100%. So this is an ST segment elevation MI, and they've conveniently circled some of the ST segments for us. So you can see how this makes it easier to diagnose. You've got a big ST segment elevation here and there. So the patient has those changes, then they also are complaining of chest pain, and you know, okay, we've got an ST segment elevation MI, and we can call the heart center and get them transferred. Here's another example. Got the big ST segment elevation in lead 1 here, AVL. You got some reciprocal changes over here in AVF, V2, V6, lead 3. So again, we've got a big ST segment elevation MI. We can call the heart center and get them going. Here's a nasty looking one. Huge ST segments. You know, we commonly refer to those as tombstones. You've got your ST segment inversion there, your reciprocal changes, again, nasty EKG. Again, pretty easy to diagnose based on the EKG changes. And as we were talking about earlier, this is uncommon. We get, we probably average somewhere like 30 or 40 chest pains a month in the ER. We probably average one acute ST segment elevation MI a month, and then we've got all these nebulous chest pains that get admitted or sent home for follow-up or transferred for definitive stress testing. So here's a non-STEMI. You can see we've got the ST segment depressions in V2, V3, V4, V5. Abnormal, not grossly abnormal. And most of the time, you know, this is a good EKG for teaching purposes, but most of the time, those segments are a little bit more subtle than that. So you've got somebody and you say, well, it's not quite normal. We're going to admit them for rule out, and then 3 hours later, 6 hours later, their biomarkers are positive.
I like to call those, there's no injury pattern on that particular EKG. There's all kind of stuff. There's no true injury pattern that you can say just from that EKG.
Right. Here the ST segments are a little bit more significant there in V4 and V5. You can see them pretty depressed. It's, you know, this is pretty abnormal EKG. Again, for most of the in STEMIs, this is not what you see. You see something more subtle, and then it evolves over time. And then here's another one, and you can see again the ST segments being depressed in V5 and V6. So this is the relationship of the 12-lead EKG to the coronary anatomy. And I don't know how, I'm pretty sure everybody else is kind of like me. There are some things that I just cannot remember no matter what, and this is one of them. So I always flip open the little book to look at the diagram so that I know what segments I'm talking about. So here it shows you the EKG leads and what section of the heart it represents, so that when you have the abnormalities in those leads, you know what part of the heart's being damaged. We're going to go to the next one, which is actually going to show you the then associated arteries. So your left main, and then circumflex comes off of that, and your left anterior descending. You guys have probably heard of the widowmaker. That's when you've got infarction in the left main before the circumflex and LAD, so that that whole part of the heart is not getting oxygen, and that kills people pretty quickly. All right, so we've gone through what the EKGs look like and the distribution from the arteries. Do you guys have any questions about that before we kind of move on to the next phase here? Any burning questions? No? All right. So I wanted to show you what a typical heart attack looks like in our ER. Oh, my LAD is killing me! I've got an elephant on my chest. Oh, it's going into my jaw and down my arm. I'll never be able to hold my gun again.
The nurse is always laughing at the patients.
I've been having chest pain. It started while I was shoveling snow.
You weren't mowing the grass?
It's right here. It feels like an elephant. It goes up into my jaw. All right, so obviously, again, people don't come in with all those typical symptoms, and I kind of wanted to highlight that because most of the patients come in with just, I've got some chest pain. They're not physically active like shoveling snow or mowing the lawn, as someone suggested. They're not always a 50-something-year-old male. They can be younger, they can be older. They don't always say the pain's going up in their jaw. They don't always say it's going into their arm. A couple things we also shot video of, but it didn't really work out to get it on here, was they put some makeup on me to look ashen. A lot of times people have a heart attack, they look grayish green, and it's pretty typical. That doesn't always happen. The other thing is a lot of times they will be diaphoretic and really nauseated and throwing up, but that doesn't always have to be that way. So we're going to talk about chest pain in the ER. So missed chest pain by ER physicians is one of the biggest costs in terms of malpractice to ER physicians. If you do 2 sets of cardiac markers that are negative, separated by 2 hours or more, that is around 98% accurate for predicting that there's absolutely no MI. But the U.S. population wants 100% accuracy, so that's why so many patients get admitted for chest pain rule-outs, because it's nearly impossible to rule them out. If we have, so basically, if you have somebody with chest pain in the ER, the recommendation in terms of what's safe to send home is that the only person who can be sent home is somebody who's low risk, and low risk is going to be, age, sex, smoking, family history, those types of things, with 2 completely normal EKGs, and they don't want anything abnormal on it. They don't want it to say question ST abnormalities, LVH, things like that. They want it to be stone cold normal. They might let sinus arrhythmia slide, and then and 2 sets of negative cardiac markers. So when we get those patients,
Over what period of time, Will? Are you talking 2 hours?
Minimum separation of 2 hours. So they prefer 3, but we often do 2, 3. If we have that patient and they're negative, we will often let them go home without patient follow-up. Moderate risk patients need to be admitted for serial cardiac markers. And in terms of the risk establishment, they have tried several different tools in terms of evaluating age, race, gender, smoking, family history. Nobody's come up with a very good tool, so it often ends up being gestalt. Okay, this guy's got these risk factors that are high. It really sounds like heart pain. It doesn't sound like heart pain. So it really comes down to the physician deciding what risk they are and then admitting them. So if we consider them to be moderate risk, they can be admitted for serial cardiac markers and then outpatient stress testing if those markers are negative. If they're high risk, they need to be admitted to a hospital. I said higher level of care because I'm talking about this hospital. The reason they need to go to a higher level of care is before they walk out the doors of that hospital, they need to have a definitive stress test. And the cardiologist needs to decide on that. And Dr. Roche can share, or maybe has shared with everybody, she shared with me that basically we can do treadmill stress testing on Thursdays as an outpatient, and we can do echo.
It echoes on Thursdays.
Echoes on Thursdays. And do we do any?
And we do not do any of the chemical stress tests.
No chemical stress tests. So the patient's got to be able to walk on a treadmill long enough to get their heart rate up to the required level, and then get that done. So that limits us quite a bit.
So what is, who's doing the echo? Are you somebody, a technician from?
There's a technician that comes.
Okay.
Yep, that does the echo on Thursdays, and then the stress tests that Dr. Tharp, I think, is it
Yeah,
Dr.
usually that's the
Tharp? Dr. Tharp does those on Thursdays.
I want to talk about some of the physical exam evaluation for chest pain, because used to be people really would hang their hat on a lot of these things, but when they've done the studies and looked at it, they are not very helpful. So chest wall pain with palpation. When they've done this, they've done studies and they say, oh, this guy, oh, I can reproduce the pain by pushing on his chest. What they've shown is that those people are as likely to have a heart attack as not have a heart attack. So it's basically of zero value. GI cocktail. This has been used for a long time. People thought that, boy, if I give them a GI cocktail and their pain goes away, that means it's not cardiac, I can send them home. Again, they've shown that this is not true. They say that basically when you numb it up, you may be affecting the vagus nerve, which is decreasing the sensation from the heart. These patients, you cannot use that reliably. In fact, even though it may take away pain, which is one of our goals in treating this, many of the people in the field suggest that you don't use it because they think it confuses the picture. And when the person gets admitted, instead of getting the stress test, they're going to get an upper scope, and they're not going to get stressed, and then they're going to go home and die of their MI. So